Welcome to EMTprep Pulse Check, the podcast where we help you sharpen your knowledge, ace your exams, and stay field ready. Whether you're prepping for the NREMT or looking to stay sharp in the ever-evolving world of EMS, we've got you covered. Each episode brings educational insights, real-world case reviews, and expert tips to boost your confidence, both in the classroom and on the call. Let's jump in.
Today, we're focusing on endocrine emergencies. Let's get started with a lecture brought to you by Jenna, one of our content creators. Then, we'll wrap up with a few multiple choice questions for review. Hi everyone, welcome to today's lecture on endocrine emergencies. So today's course, we're going to talk about all things endocrine emergency. Because as EMS providers, the more that we understand about the endocrine system, the normal functioning of that system, the glands, the easier it will be to determine when there are abnormalities. Because the reality is, some endocrine disorders can mimic other emergencies. And so this helps us when we go on a patient and we're working through our differential diagnoses of what is going on with this patient, always having these types of emergencies in the back of our head and knowing what to look for, how to rule in or out certain things, etc. And so we're going to focus on both the anatomy and physiology of the endocrine system itself, and then we'll talk about some emergencies that we can expect to encounter in the field. Starting with the foundation of the endocrine system, which is the endocrine glands. They are the functional units of the system. Endocrine glands are ductless, and they are what secrete hormones. Hormones are then released into our bloodstream, and hormones' jobs are to go exert effects on the target organs of the body. And really what it does is it helps regulate cell processes and body functions. So the endocrine glands are the worker bees of the endocrine system. And we're going to talk about those glands in just a moment. But the goal of the endocrine system is to help the body maintain homeostasis, right? Our body naturally wants to maintain an appropriate environment or balance known as homeostasis. When everything's working well, all the systems are firing appropriately, etc. What happens is these endocrine glands can release too much or not enough of certain hormones, and then we get out of that homeostasis. And that's where we get these endocrine disorders. It's a result of either too much or too little hormone release from the 9 glands of the endocrine system. In addition to the glands, there are a few body tissues that do have endocrine functions, which we'll mention, but there are 9 true endocrine glands that we're going to discuss. And those 9 glands are as follows: hypothalamus, parathyroid, adrenals, pituitary, thymus, gonads, thyroid, pancreas, and the pineal. So let's start with the hypothalamus. You can find the hypothalamus deep in the cerebrum, and it serves as the junction, or sometimes known as the connection, between the central nervous system and the endocrine system. So what the hypothalamus does is it receives and then responds to impulses from our autonomic nervous system. So it receives those messages, and then it releases either TRH or GHRH, which then go act on the pituitary gland and promote the release of pituitary hormones. So one thing about the endocrine system is a lot of it is a domino effect. One gland will then act on another, then will then go act on the target organ. So in this case, the hypothalamus receives that message or the impulse, and then it goes and promotes the release of pituitary hormones. Which brings us to the pituitary gland. The pituitary gland is pretty small, it's about the size of a pea, and it sits just below the hypothalamus. And the pituitary gland is divided into 2 lobes, the anterior pituitary and the posterior pituitary. And both of those sections have different jobs and responsibilities. The posterior pituitary produces 2 hormones. It produces antidiuretic hormone, which helps cause retention of body water. So if we are releasing or secreting too much fluid, ADH kicks in and tells us to retain some of that to maintain that homeostasis that our body is trying to achieve. The posterior pituitary gland is also responsible for producing oxytocin, commonly talked about in obstetrics because it causes uterine contraction and lactation. Then we have the anterior pituitary gland, and it's often referred to as the master gland because it regulates other endocrine glands. And the anterior pituitary gland is busy. It has a lot of jobs and secretes a lot of hormones, 6 to be exact. It secretes human growth hormone, which targets almost all of our body's cells and helps with growth and our metabolism. It secretes thyroid stimulating hormone, which again goes back to that domino effect of it targets the thyroid. So the anterior pituitary gland releases thyroid stimulating hormone, which then goes and works on the thyroid and tells the thyroid what to do. It secretes adrenocorticopic hormone, which targets the adrenal cortex. It secretes follicle stimulating hormone, which targets our gonads, as well as our luteinizing hormone that also targets our gonads. And the 6th hormone that the anterior pituitary gland releases is what's called prolactin. And it targets the mammary glands of females, and it stimulates the production of breast milk, but it can also have effects on menstrual periods, fertility, and sexual function. So again, the posterior pituitary gland just has those 2 hormones, whereas the anterior is a lot busy and has a lot more responsibilities within the endocrine system. Next, we have the thyroid gland. This is one that's pretty commonly talked about. You're probably a little more familiar with this one than maybe some of the others. And it's located in the neck, anterior to the laryngeal cartilage. The thyroid gland is actually also made up of 2 lobes that are connected by a band of tissue called the isthmus. And the thyroid gland produces 3 hormones: T3, T4, and calcitonin. T3 and T4 are very similar in that they both stimulate cell metabolism. One is just largely active in the system, whereas the other one is largely inactive most of the time. And then calcitonin is what lowers our blood calcium levels. So again, it all works as that balancing act of how do we achieve and maintain homeostasis. So if our blood calcium levels are getting too high, calcitonin kicks in to lower it and get it back to where it is supposed to be. Just posterior of the thyroid, actually on the posterior lateral surface of the thyroid, there are 4 glands that we refer to as parathyroid glands. They're very small. They're estimated about 5 millimeters maximum in diameter, and they basically sit on the 4 corners of the posterior side of the thyroid. And the parathyroid gland secretes, rightfully named, the parathyroid hormone, right? PTH. And the goal of PTH is to increase blood calcium levels. So you can see that the parathyroid hormone and calcitonin work together kind of as a scale to keep our blood calcium levels equal and level. So if one gets out of whack, the other one will come in and bring it back to the natural state that our body's trying to stay in. Next, we have the thymus gland. The thymus is located in the mediastinum and sits just behind the sternum. It's much larger in children, and then as we get older and we mature, it becomes basically a small remnant of fat and fibrous tissue in adults. And the thymus gland secretes thymosin, which promotes maturation of T lymphocytes, which are the cells responsible for cell-mediated immunity. So it helps with our immune system, etc. Then we have probably the most talked about endocrine gland is the pancreas. Pancreas is located in the upper retroperitoneum, and it actually also has exocrine functions that work in our digestive system. But the pancreas also has endocrine tissue that's found in clusters called the islets of Langerhans. And there are a few different types of cells that make up those clusters, but the three most important cells are alpha cells, beta cells, and delta cells. Alpha cells are what secrete glucagon, which help increase our blood glucose levels. And on the other end of that spectrum, beta cells secrete insulin, which decrease blood glucose. And we'll talk about those more in depth when we talk about what can happen when our endocrine system is out of whack. In the context of diabetes, we'll talk a little bit more how those two cells work together. But for now, it's important just to kind of lay that foundation of that's what those two cells are responsible for. And then we have delta cells, which secrete somatostatin, which inhibits the secretion of insulin and glucagon. Next, we have the adrenal glands. The adrenal glands are located on the superior surface of the kidneys, and it consists of two anatomic divisions, the adrenal medulla and the adrenal cortex. So the adrenal medulla is the inner portion, and it secretes epinephrine and norepinephrine of the sympathetic nervous system. So when we talk about fight or flight, that's often the system that we're dealing with is the adrenal medulla with that epi and norepi. The adrenal cortex is the outer portion, and it secretes three classes of steroid hormones, including glucocorticoids like cortisol. And cortisol inhibits the inflammatory reactions and immune responses. The adrenal cortex also secretes mineralocorticoids like aldosterone, which contributes to salt and fluid balance in the body by regulating our sodium and potassium levels. And then we have androgenic hormones like testosterone that affect bone and muscle mass, as well as sexual maturity in males. It is an important note that this is also found in females. It just can present a little bit differently, and the levels are different. Next, we have the gonads, which are responsible for sexual maturation of puberty and also reproductive function. So in females, they have ovaries, which are paired organs the size of an almond roughly, located in the pelvis on each side of the uterus. And the ovaries secrete two hormones, estrogen and progesterone. So estrogen is responsible for the development and maintenance of secondary female sexual characteristics. And progesterone, similar to the luteinizing hormone, is often talked about in obstetrics, and it is known as the hormone of pregnancy. And then on the counter, we have testes, which are located in males, and it is located outside of the abdominal cavity in the scrotum, and it secretes testosterone, which promotes the development and maintenance of male secondary sexual characteristics. And then the final endocrine gland that we're going to talk about is the pineal gland. And this is located in the roof of the thalamus of the brain, and it releases the hormone melatonin in response to changes in light. And melatonin is super commonly talked about because it plays a role in a person's mood, our quote-unquote biological clock, our day length, our lunar cycles, and really our circadian rhythm. So this is a gland that can really have potential to get out of whack, especially those that work swing shifts or night shifts, because it goes against our natural response to the changes in light. It also can be implicated in seasonal affective disorder in places that don't see much sunlight, because again, this hormone is released in response to changes in light. So without those changes, our body has a hard time setting a natural mood, a day length, our lunar cycles, etc. So I mentioned in the beginning of this lecture that there also are some organs with endocrine activity that are separate from endocrine glands, but are included in the endocrine system. And those organs include the placenta. So during pregnancy, there's a placenta that is formed, and it secretes HCG, human chorionic gonadotropin. The intestinal tract has endocrine activity by secreting gastrin and secretin. the heart, which produces atrial natriuretic hormone, and then the kidneys, which secrete renin and also erythropoietin. So now that we've kind of set that foundation, we're going to now move into endocrine disorders as well as emergencies. So we're going to talk about some disorders of the pancreas, some disorders of the thyroid gland, and then some disorders of the adrenal gland. And we're going to talk about what happens when we either have hypo or hyper secretion of hormones from those associated glands and the overall effect it can have on our patients. So starting with diabetes, right, a disorder of the pancreas. So it's estimated that approximately 15 to 16 million people in the US alone are affected by diabetes. And this is a super prevalent call that we go on in the pre-hospital field. Whether it's too high or too low of blood sugar, it's a very common call type for us as pre-hospital providers. And so understanding how the disease process works, as well as recognizing signs and symptoms of the disorder, is super important. So when we talk about diabetes in general, our body relies on energy that we get from metabolism to perform cell processes, right? Our body gets things, it breaks it down to use for energy, and then our cells can do the processes and the jobs that they need to do. Glucose is a large molecule that can't readily pass through the cell membrane to meet the body's energy demands. So because it is a large molecule that can't just pass through the cell membrane, it requires insulin to move glucose into the cell. So without insulin, glucose can't enter the cell, which means glucose just circulates in our bloodstream until insulin comes along and helps it go into the cell to then be metabolized and used for our energy. So therefore, we need sufficient insulin circulating in our bloodstream to satisfy cellular needs. So when we talk about day-to-day, what is a normal blood glucose level? It's anywhere from 80 to 140 milligrams per deciliter, right? Anything below 80 is considered hypoglycemia. Anything above 140 is considered hyperglycemia. And along with the pancreas, our kidneys help monitor and maintain blood glucose levels because our kidneys filter our blood, and the amount of glucose reabsorbed depends on the glucose levels in the blood. If our blood sugar is above 180 milligrams per deciliter, our kidneys cannot reabsorb more than that. And so what our kidneys will do as a result, we will excrete it through our urine to help lower our blood sugars down. So anything above 180, glucose gets lost in our urine. So there are a few types of diabetes. Type 1, type 2, and there's also gestational diabetes, which we're really not going to touch on in this presentation, but we are going to talk about type 1 and type 2. So in a type 1 diabetic, our pancreatic beta cells, which are the ones that secrete insulin, no longer produce and secrete enough insulin that our body's requiring. And because of that, our glucose cannot be moved from the bloodstream into the cells, right? No insulin, glucose will continue to just circulate in the bloodstream, looking for insulin to help take it into the cells. But for some reason, our beta cells aren't producing enough, and so our body has to turn to fatty acids as a primary energy source because it doesn't have that glucose to break down. When this happens, when our body turns to fatty acids, we break down and metabolize and leave behind what are known as ketone bodies. And ketone bodies are what is found in the urine of type 1 diabetics. And we'll talk about that coming into play here momentarily. The other note on the type 1 diabetes is that oftentimes it's managed by prescribing insulin for patients, right? They need more insulin, their body's not producing it, so we find a synthetic way to administer insulin so that glucose in our bloodstream can then be absorbed into our cells to be used for energy. So one major thing that can happen with type 1 diabetes is what's known as diabetic ketoacidosis, right? DKA. And DKA patients present with a variety of signs and symptoms. Typically, we see the onset about 12 to 24 hours. So it's kind of a slower onset. Their blood sugar is typically greater than 250 milligrams per deciliter. Patients in DKA are often exhibiting what's referred to commonly as the 3 Ps, which is polyuria, polydyspia, and polyphagia, which is excessive urination, excessive thirst, and excessive hunger. These patients are often dehydrated, so they'll present with dry, warm skin, dry mucous membranes. They may complain of some abdominal pain, nausea, vomiting. They may be tachycardic. Some patients present with a fruity odor on the breath. These patients are in an acidotic state and sometimes can present with Kussmaul respirations. And in severe cases, these patients can be unconscious or in a coma. So if you do go on a patient that you believe is experiencing DKA, treatment kind of follows ruling out other causes, right? We talked about that in the beginning, that endocrine emergencies can present as other medical emergencies. So making sure that they're not having a stroke and ruling out some of those other potential causes. You obviously want to obtain a blood glucose reading, manage and maintain the A, B's, and C's, and any life threats. If it's within your scope, start an IV and start some fluid resuscitation because of that dehydration that they're going to be experiencing. And then rapid transport to a definitive treatment. Because really the definitive treatment is insulin administration and monitoring over a couple days to re-regulate their system. Then we have type 2 diabetes. So type 2 is a result of a decline in insulin production or deficient response to insulin. So either we're not producing enough insulin, but we're still secreting some, or our bodies have become insulin resistant and our cells, for one reason or another, are not using the insulin as they should. This is one of the reasons why obese patients are more likely to develop type 2 diabetes. Because of their increased number of fat cells, they are less responsive to insulin. However, insulin's presence in this case is usually enough to keep the body from switching to fats as a primary energy source. So in type 1, we mentioned that the body can switch to using and burning fatty acids. In this case, there is no backup plan because there is enough insulin to keep the body from switching, just not enough to keep our body in a good state of homeostasis. But because we don't switch to fatty acids, we do not produce ketone bodies. So no ketones are produced in type 2 diabetes. These patients are also less likely to be prescribed insulin because, again, the issue is not necessarily that there is no insulin. It's oftentimes that our body doesn't know how to properly utilize and use insulin. So giving them more won't help the problem in this case. So with type 2 diabetics, they can develop a condition called hyperosmolar hyperglycemia non-ketotic coma, more commonly known as HHNK. HHNK develops over several days, and these patients present with a blood sugar much higher, like up to 1,000 milligrams per deciliter. Oftentimes, our blood glucose monitors in the field will just read high. They do often also present with the 3 Ps, polyuria, polydyspia, and polyphagia. They're also going to be dehydrated, dry skin, dry mucous membranes. They're going to be tachycardic. Some patients may present with orthostatic hypotension, or in severe cases, be unconscious or in a coma. Treatment for these patients is very similar to those with DKA. Performing a good assessment to rule out any other causes, obtain a blood glucose reading, maintain their A, B's, and C's, start an IV and give those IV fluids going. Long-term management of this condition often includes diet and lifestyle changes. But again, for us, it's going to be transport to a definitive treatment center and then let them take care of the long-term plan. So on the opposite end of the spectrum of the high blood sugars, the other disorder of the pancreas and diabetes that we can see is low blood sugars, hypoglycemia. Again, this is often a frequent call for us as EMS providers. And this results because our body cells require energy in the form of glucose, right, for all of our cell processes. And this can occur when a patient takes either too much insulin or has too little glucose intake. So if a patient is a type 1 diabetic and is prescribed that synthetic insulin, they can take too much of it, or they can just not eat, not be aware of their blood sugar, and their blood sugar can drop. This can happen super quickly, like within minutes to hours. And typically we start to see patients become symptomatic when their blood sugar falls below 60 milligrams per deciliter. But that is different for different patients. Some patients may be symptomatic at 80, some may be not symptomatic until 40, but 60 is about where we say patients start to become symptomatic. So hypoglycemia can present in a number of ways. It can mimic other medical emergencies, and so that's why obtaining a blood glucose level is super imperative to determine, is it a blood sugar issue or is it something else? These patients can be diaphoretic, they can be tachycardic, they may, if they're able to, complain of hunger and weakness. Some may present with seizures or just general altered mental status. It's also not uncommon that these patients are agitated, combative, etc. So when you are treating these patients, we want to perform a good assessment, right? Determine a blood glucose level. And if it is determined that a patient needs sugar because their blood sugar is too low, there's a few ways we can do that. If your patient's conscious and has an intact gag reflex, you feel confident that they can take medication orally, they can use glucose paste, or really any oral sugar source. Sugary juices, candies, glucose tabs all work great. If your patient cannot take an oral glucose of some sort, we can start an IV and administer 25 to 50 grams of D50 or whatever IV dextrose percentage you guys carry. If you cannot obtain an IV, we can administer 1 milligram of glucagon IM. And you always want to have the consideration of administering 100 milligrams of thiamine if alcoholism is suspected in these patients. Now we're going to talk about some disorders of the thyroid. So typically, thyroid dysfunction is a chronic condition, not so much an acute emergency. However, there are some thyroid emergencies that we may encounter, such as Graves' disease, thyroid storm, and myxedemia, which we're going to talk about. Starting with Graves' disease. So this is a result of hyperthyroidism, so too much thyroid. And it's a prolonged exposure of body organs to excess thyroid hormones. Results from an autoimmune origin that stimulates the thyroid gland to produce excess thyroid hormone. There are a few risk factors for patients that are at higher risk for developing Graves' disease, including being female. There are hereditary factors, stress, smoking, and then viruses and infections all make patients at a higher risk for developing Graves' disease. Graves' disease presents with an increased metabolism, agitation and insomnia, warm skin temperature and poor heat tolerance. Patients may be super weak, short of breath. They may have some cardiac dysrhythmias. And then they also sometimes have physical signs like protruding eyeballs or a goiter, kind of that enlarged thyroid, which is literally just excess thyroid hormone sitting and building up on the sides of their thyroid. So those are all things to be on the lookout for, especially if a patient has a known thyroid issue, that this should be in your differential diagnoses. Treatment for these patients, including treating presenting signs and symptoms, right? What are they presenting with? If they have a cardiac dysrhythmia, you need to treat it. If they are nauseous, vomiting, diarrhea, that may require treatment. It's really just treating what's in front of you. And you also can consider some steroid therapy. Dexamethasone has been shown to reduce circulating T4 levels. So reducing some of that thyroid hormone can be helpful in some cases. Then we have what's known as the thyroid storm. And this is what is truly a life-threatening emergency. And it's caused by a shift of thyroid hormone in the blood from the inactive to the active state. So I mentioned that half of the thyroid is largely inactive, half is active. If that inactive part moves to the active state, we can get a thyroid storm. This can be associated with severe psychological trauma or stress, or it can be a result of an overdose of thyroid replacement hormone. So if someone's on thyroid replacement for hypothyroidism, but they take too much, this can result in that inactive turning active state, resulting in a thyroid storm. Thyroid storm presents with a high fever, like 106 degrees or higher, irritability, patients can be delirious or in a coma, they can be tachycardic, they can be hypotensive, and they can present with vomiting and diarrhea. So treatment is similar to Graves' disease, where it's really treating signs and symptoms. There is a pretty big focus on reducing that fever, if at all possible. But other than that, it's supportive care. Do they need oxygenation? Do they need fluid resuscitation? What kind of cardiac monitoring are they requiring? And what treatment is that resulting in? Etc. Then we also have some disorders if a patient is experiencing hypothyroidism. So insufficient release of thyroid hormone leads to a low metabolism. This can be either congenital or it can be acquired. It does affect both males and females, although for some reason there is a higher prevalence in middle-aged women. And hypothyroidism causes poor organ function and poor response to challenges such as exercise or infection. So our body doesn't cope and compensate as well for those things, with what's known as advanced myxedemia being the true medical emergency of hypothyroidism. So like we were just saying, hypothyroidism basically slows everything down, right? Your metabolism slows down. So patients are going to be complaining of fatigue and slowed mental function. They may just feel like they're walking in concrete or in a daze. They're going to be lethargic. Their reflexes are slowed down. They have pale, cold, doughy skin, constipation because their digestive tract is slowed down. They're going to have a decreased appetite, but gaining weight. They may have puffy face, thinned hair, enlarged tongue, etc. Treatment is presenting signs and symptoms, focusing on maintenance of their A, B's, and C's, and monitoring cardiac and pulmonary status. It is important, again, if it's within your scope, to establish IV access and start some fluids to prevent any further hypotension. We do want to make sure that we stabilize these patients' blood pressures, but be cautious with the use of pressors due to the possibility of that causing arrhythmias. So just something to kind of be aware of. And then finally, we have some disorders of the adrenal gland. So we're going to talk about hyperadrenalism and hypoadrenalism. Hyperadrenalism, more commonly known as Cushing's syndrome, is caused by excessive cortisol in the blood. This can be caused either by medications or tumors of the pituitary gland. So one thing to keep in mind if you are assessing a patient is to look for their history of have they been on steroid treatments, either for COPD, asthma, cancer, but a history of steroid treatments makes patients more susceptible to developing Cushing's syndrome. This can cause high blood sugar, can cause diabetes, can cause osteoporosis. It also just predisposes patients to infection and can delay their healing. These patients often complain of weight gain. They may have what's known as a moon face appearance or an accumulation of fat on the upper back, known as the buffalo hump. Those are two very telltale signs of this disorder. They bruise easily, again, because they have that delayed healing. Women may develop facial hair, and patients may complain of mood swings or impaired memory. Treatment is mostly supportive, keeping in mind that these patients do have a higher incidence of cardiovascular disease and hypertension. And just be cautious when starting IVs because they do have thin, fragile skin and are susceptible to infections that they can't fight off as well. And so be aware of using really good techniques and just being aware of that. Then we have hypoadrenalism or Addison's disease. So this occurs when our adrenal cortex doesn't produce enough steroid hormones. So we don't produce enough cortisol and aldosterone. Oftentimes, this is a result of an autoimmune disease, or it can be hereditary, but it leads to disturbances in water and electrolyte balance, and increased sodium excretion. We also retain potassium, which can lead to hyperkalemia and ECG changes. These patients are going to complain of progressive weakness, progressive fatigue, a decreased appetite, and weight loss. So they're not eating as much, and they're losing weight. So they're not eating as much and they're losing weight as a result. They have hyperpigmentation of the skin and mucous membranes. They're going to be dehydrated. They may have some electrolyte imbalances. And again, maybe some EKG changes as a result of that. And in some cases, it can result in hypotension and cardiovascular collapse. Treatment for these patients is treating presenting signs and symptoms, closely monitoring their cardiac rhythms, oxygenation status, and blood glucose levels. Treat any cardiac dysrhythmias that they may have as a result of that electrolyte imbalance, and then establish an IV and be aggressive with your fluid resuscitation. So throughout this lecture, we've learned that the endocrine system is responsible for many of the body's metabolic processes. It has a huge responsibility in keeping our body in homeostasis. And this lecture kind of went over what can happen if we have too much or not enough secretion of hormones from certain endocrine glands. The next part is for us as providers in the pre-hospital world is oftentimes our job is not to fix the endocrine disorder, right? These are disorders that existed before we met this patient and will exist after. Our job is to manage the presenting signs and symptoms. But the more knowledge of the endocrine system that we have, the glands that encompasses, the roles that it plays in the homeostasis process of our body, the better off we are when we're assessing and treating patients that may be experiencing these endocrine emergencies. So hopefully this was a good review for you guys on the endocrine system. Thank you for tuning in to today's lecture.
Now let's transition into some multiple choice questions.
Question number 1. Which hormone is primarily involved in diabetes insipidus? Answers are glucagon, antidiuretic hormone, insulin, or somatostatin. Correct answer, antidiuretic hormone. Diabetes insipidus is different than diabetes mellitus. Diabetes means to quote-unquote pass through. Insipidus means quote-unquote without taste. This condition results in excessive thirst and urination. However, it is due to improper regulation of water within the body due to an ADH imbalance rather than high levels of circulating blood glucose. Question number 2. Which of the following is not an endocrine gland? Potential answers are gallbladder, hypothalamus, pancreas, or testes. Correct answer, gallbladder. Endocrine glands produce hormones that regulate the body's organs and systems. The gallbladder is not an endocrine gland, rather a small organ that serves to store bile produced by the liver. Other endocrine glands consist of the adrenals, thyroid, parathyroid, testes, and pituitary. Question number 3. Which endocrine gland is responsible for the fight or flight response? Answers are pituitary, thyroid, pancreas, or adrenal gland. Answer is adrenal gland. The adrenal gland is responsible for the release of epinephrine, norepinephrine, and cortisol, among other hormones. These hormones are involved directly in the body's response to a threat. Question 4. If a patient is taking levothyroxine and overdoses, which of the following is most likely to occur? Answers are low metabolic state, no effect, high metabolic state, or myxedemia. Answer is high metabolic state. Levothyroxine is a common thyroid replacement hormone. An overdose on thyroid replacement hormones can result in a high metabolic state. Next question. A substance that prevents the release of antidiuretic hormone from the posterior pituitary gland would cause which of the following? Answers are decrease in circulating blood volume, increase in circulating blood volume, decreased urination, or increased blood pressure. Correct answer, decrease in circulating blood volume. ADH is a hormone that maintains fluid volume in the bloodstream. It affects the kidneys and decreases urination. Different substances can interfere with the release of ADH, for example, alcohol. This results in dehydration due to increased urine production. Question number 6. Which structure serves as the junction between the nervous and the endocrine systems? Answers are medulla oblongata, hypothalamus, thymus, or pineal gland. Correct answer, hypothalamus. The hypothalamus is located in the cerebrum of the brain and is the connection point between the nervous system and the endocrine system. Next question. How many major glands are in the endocrine system? Answers are 2, 6, 8, 10. Correct answer, 8. The 8 major glands of the endocrine system are as follows: hypothalamus, pituitary gland, thyroid gland, parathyroid gland, thymus, pancreas, adrenal glands, and gonads. The pineal gland is also part of the endocrine system, although most of its function is unclear. Question number 8. Breastfeeding may be encouraged post-labor as it helps reduce postpartum hemorrhage. Which hormone is responsible for this mechanism? Answers are prolactin, oxytocin, estrogen, or thymosin. Correct answer, oxytocin. While prolactin is involved in the release of milk from mammary glands, oxytocin simultaneously causes milk release and uterine contraction. Uterine contraction helps return the uterus to its appropriate size and inhibits postpartum hemorrhage. Question number 9. Which endocrine gland is primarily active in childhood, but function reduces dramatically in adulthood? Potential answers are parathyroid gland, thyroid gland, pineal gland, or thymus gland. Correct answer, thymus gland. The thymus is an endocrine gland responsible for the release of thymosin, which stimulates the creation of T lymphocytes. Question 10. Insulin production occurs in the what? Answers are pancreas, kidneys, thyroid, or adrenal gland. Correct answer, pancreas. The pancreas is responsible for the production of the hormones insulin, glucagon, and somatostatin.
Thanks for tuning in to EMTprep Pulse Check. If you found today's episode helpful, be sure to subscribe, leave a review, and share it with your classmates and crew. For more test prep tools, study guides, and practice exams, head over to EMTprep.com. Until next time, stay sharp, stay safe, and stay on pulse.